Welcome to our session today, JIA 101, the first 2 years. Our speaker today is Dr. Sampath Pahal. Dr. Pahal is Chief of the Division of Rheumatology at Children's Healthcare Atlanta and also a Marcus Professor at Emory University. We are very excited to have you here today, so welcome, Dr. Pahal.
Thank you. Okay, thank you for watching this. It's my pleasure to give this presentation on the juvenile arthritis, the first 2 years. And I wish I could have been doing this in person, but we adapt for this virtual world, and so we'll get going here. So I would like to show this disclosure that I serve on the macrophage activation syndrome advisory committee for Novartis, but this has no role in my presentation. I always like to start off with some real life cases of arthritis and how it affects individuals. And here is a case of a famous painter you may have heard of, Renoir. He's a French painter who was born in 1841. By 30s, he was one of the most successful painters of his day. But by the time he was 50 years old, he developed rheumatoid arthritis and he died at age 78. And this is one of his earlier paintings, thought to be one of the most expensive paintings ever done, very exquisite detail. And then towards this later on in life, he had a painting, and this one, not as intricate as before when he was actually painting with arthritis. So juvenile arthritis was recognized first by Dr. Still, George Frederick Still, and he is actually credited as having been the first person to describe chronic arthritis in children in 1897. So to this day, one of the subtypes of arthritis is called Still's disease, and the rash is called Still's rash. And so this is he. But even before that, there's this painting from 1608 by Caravaggio, an Italian painter. And when you look at the child who was the model for this particular picture, clearly there's evidence of arthritis. So the joints are swollen, the jaw is small, every joint seems to be held in flexion. And this typically indicates chronic arthritis. So juvenile arthritis has been around for a lot longer than we realize. JIA, which is the usual abbreviation for this, is not a single disease, but a group of heterogeneous, meaning different types, chronic arthritis in children. And it is a good model of inflammatory arthritis because it looks like a lot of adult onset arthritic conditions. And in the old days, we used to call it juvenile rheumatoid arthritis, but most of the children do not have the blood test called rheumatoid factor. So we don't use that word anymore. We use juvenile idiopathic arthritis. In Europe, they used to call it juvenile chronic arthritis. So this term JIA is thought to be a combination of all the different rheumatology groups using the same terminology. And JIA looks a lot like rheumatoid arthritis under the microscope. You can't even tell the difference. Inflammatory bowel disease, psoriasis, and ankylosing spondylitis often overlap with juvenile arthritis. And children with JIA have an increased risk of celiac disease and thyroid disease. So it's a good model for autoimmune diseases. This is an overview slide of the different categories or subtypes of juvenile arthritis, and we'll talk about each of them in the next few slides. But the most common one is oligoarticular, and then we have the polyarticular and systemic enthesitis-related arthritis and psoriatic arthritis. Juvenile arthritis is an autoimmune disease, and it's also thought to be what's called a complex disease. And complex diseases are those in which multiple factors are required to develop the disease. So in one way of thinking, let's say there's an ordinary healthy person who is born with certain genes. So we are all born with certain genes, and some of them could be protective and some of them could be risk-inducing. But that's just by itself not enough. And then there may be something else, maybe exposure to cigarette smoking or infections that may predispose some individuals to develop what is called a preclinical autoimmunity, right? They do not have a disease yet, but they are probably primed to develop one. And then there may be another infection or even some other things we don't understand that may lead to the development of an autoimmune disease. And this is probably true for many autoimmune conditions that we take care of, including juvenile arthritis. And so when we think about the two big factors, the genetic factors as well as the environmental factors influence a person developing disease. Monozygotic twins, so that means identical twins, siblings, and cousins of children with JIA have a higher risk of developing the disease. So there was one study from a while ago that showed that identical twins of kids with JIA have a 250 times greater risk of developing JIA than the population. When we look at siblings, the siblings have a 12 times greater risk than the population, and first cousins have a 6 times greater risk than the population. By the time we go to the second cousin, they have not an excess risk compared to the general population. So this indicates that there are definitely genetic influences that lead to developing JIA. We also know that children with juvenile arthritis have more autoimmunity in themselves and their relatives. So there are a couple of studies that have shown that thyroid disease seems to be more common in juvenile arthritis, and celiac disease might also be increased in JIA, although this is not as clear-cut. There are studies showing that it does, and we have shown that it does not appear to be. We do know that type 1 diabetes, for instance, seems to happen 6 times more commonly in JIA than in the healthy population. We also know that relatives of children with JIA have a 3-fold excess of autoimmunity compared to relatives of healthy individuals. And when we look further, it seems to be the maternal relatives. So that is maternal aunts and maternal grandmothers have more autoimmunity than paternal aunts and paternal grandma. So this indicates that there are definitely complex genetic factors influencing the development of disease. And this allows us to look further to identify these kinds of factors. There is a registry called the CARA registry, and this is supported by the Arthritis Foundation. So thank you, Arthritis Foundation. The Childhood Arthritis and Rheumatology Research Alliance, and this is a registry involving thousands of children with juvenile arthritis, also has children with lupus and dermatomyositis. And we asked what is the proportion of autoimmunity among the first degree relatives in this registry. And what we found that children with juvenile arthritis have an increased family history of individuals with other inflammatory arthritic conditions. And similarly, children with lupus have more number of relatives with lupus. So talking about the individual types of arthritis, let's start with the most common one, the oligoarticular JIA. So oligoarticular JIA involves between 1 and 4 joints in the first 6 months. And it's seen most often in the young child, so under 5 in majority of them. Typically, large joints are involved, and the most commonly involved joint is the knee. And sometimes the knee presents without any symptoms at all, other than perhaps a stiffness in the morning. And the parents notice that this knee is swollen and you didn't even know it was there before. And most of the time there's no injury, and this may not even be painful, except for being stiff in the morning and limping in the morning. Children with oligoarticular juvenile arthritis have a risk of developing uveitis, which is inflammation in the eye, in about 20% of cases. And with overgrowth, one of the limbs can grow longer than the other. So you may have limb length discrepancies that can also lead to limp even after the arthritis has gone away. Polyarticular JIA, this is the term given to arthritis when you have 5 or more joints in the first 6 months. And this is more common in girls. And there are 2 categories within this. The rheumatoid factor negative polyarticular JIA. This is seen in the young child where the onset is between 1 to 3 years and most often before 6 years. And they have some risk of developing the uveitis. And then the older teenager can have the rheumatoid factor positive polyarticular JIA. And this is very similar to adults with rheumatoid arthritis. So this is younger onset of rheumatoid arthritis, and they have a particular blood test called rheumatoid factor. And you can see in these pictures, all the fingers are swollen in these different joints. And then there's a subtype called systemic juvenile idiopathic arthritis, or systemic JIA, and this is the one we call Still's disease. This is one of the dramatic presentations of arthritis. Oftentimes, children with this are mistaken to have an infection, and many of the time they are admitted to the hospital, and they have very high daily recurring fevers. They have a rash seen in about 90%. Their arthritis sometimes comes behind, and that may make it harder to diagnose. They can have enlargement of the liver and spleen and lymph nodes. They can have some chest pain with fluid around the heart or lungs. These children do not develop uveitis, and their blood work usually shows a lot of abnormality. They have elevation in their white count and platelet count. They have some anemia, and they are at risk for a complication called MAS, or macrophage activation syndrome, and these slides kind of show that. And what happens in this is macrophage, which is a kind of an immune cell, gets activated, and it starts to eat and destroy other types of cells. And this can lead to serious complications. And this has to be promptly recognized and treated. ERA, or enthesitis-related arthritis, is when you have arthritis and enthesitis, or arthritis or enthesitis. And enthesitis is the term given to inflammation of tendon and ligament attachments. Typically, you present with heel pain or pain in the bottom portion of the knee. And when you have that plus arthritis, we call it ERA. But sometimes you can only have one of them. Maybe there's a swollen knee, but nothing else. And then we look for the other clues. If there's a history of back tenderness and pain, if there's presence of a particular blood test called HLA-B27, there's a family history of ankylosing spondylitis, acute iritis, which is the acute presentation of eye pain, or onset of arthritis in a boy after the age of 6, it's more likely to be favoring enthesitis-related arthritis. Psoriatic arthritis is the term where you have psoriasis and arthritis. Psoriasis is an inflammatory condition of the skin. Sometimes it's only the arthritis that presents, and the skin condition may come later. And some clues for that are what's called dactylitis, which is where a whole digit is swollen, when a whole toe is swollen, and we call them sausage toes. And you can have these pits in the nails. So there's little dots in the nails, and that could be a clue that this is going to become psoriatic arthritis. The rash, when it's present, it's pretty easy to diagnose, but sometimes it looks like eczema, and you may not show up with the rash until later on. If there's a family history of psoriasis in a first-degree relative, so that's parents or siblings, then that also is a clue. Now, this classification is fairly strict, and part of the reason is to identify clear categories of juvenile arthritis that allows us to do research and also understand the outcomes for each of them distinctly, instead of mixing all the types of juvenile arthritis as if they're all one. And what we will notice is there are a number of different exclusion criteria, and it's probably more of an academic question. It's more for what the doctor thinks it is. As far as the treatment goes, we clinically think of them as one of these different 6 categories and start with the treatment. But this sometimes makes it about 10% of children can belong to this undifferentiated group, and over time they become more clear as to what they would really follow. Most children with arthritis develop it earlier on in life. We usually use 16 as a cutoff by which you should develop JIA. So majority of the kids have it before the age of 6. And a lot of that is due to the oligoarticular JIA and the rheumatoid factor negative poly, shown here in this teal or turquoise color. The rheumatoid factor positive arthritis is pretty rare in the early childhood and starts to become more common during teenage years and beyond. Systemic arthritis can be present at any age, and ERA, or enthesitis-related arthritis, also becomes a little bit more common as the children get older. And majority of the types of JIA are more common in girls. So the rheumatoid factor negative poly and the rheumatoid factor positive poly and oligo are very female predominant. The enthesitis-related arthritis tends to favor boys more often, and the systemic is almost equal, slightly more male predominant. Now, I talked about uveitis, or inflammation of the eye. So this is called a JIA-associated uveitis. Sometimes we call it iritis, and iris is the name of this portion of the eye, that the colored portion. And when this is present, it can happen in between 2 to 16% of all children with JIA and up to 20% of children with oligo-JIA. And this is chronic and silent. It doesn't have any symptoms earlier on. The only way to pick it up is to go to the eye doctor every 3 to 6 months, depending on the type of arthritis, so that they can be screened for it. Now, about 8% of children with the enthesitis-related arthritis develop acute painful uveitis, and this typically warrants a visit to the eye doctor, and they can recognize and treat it. And the examination is something called slit lamp exam. There are a variety of treatments, including topical treatments, eye drops, as well as systemic treatment with similar medications that also treat the arthritis. Now, talking about treatment, if you were to go and look on the internet, you will notice there's a variety of treatments for arthritis, which are all unconventional. And generally, that means there isn't any satisfying, simple, easy fix. That's why there are so many of these old remedies out there. And some interesting ones we have all heard about are copper bracelets or ginger, turmeric, fish oil, or acupuncture. And there may be some benefit to some of these things, to be honest. And then there are some outlandish things out there, WD-40, similar to using it on a door, gin-soaked raisins, avoiding certain kinds of food, and then the really bizarre ones out there, fire cupping, helminthic therapy. So this is getting infested with a worm so that arthritis gets under control, getting buried in hot sand, bee stung, and then the last one is urotherapy, and I want to explain that. But thinking about treatment, before we go to treatment, we want to know what's going on here so we can be a little bit more specific. So what is a joint like this doing in a nice girl like her? So that's really the question. So when we were to look at the fluid and the blood of children with arthritis, we find that there are certain what we call cytokines. These are proteins that mediate inflammation. They are elevated in children with JIA compared to healthy children. And so one of them is TNF-alpha, interleukin 8, interleukin 6, interleukin 1. And the reason these sound familiar is because many of these can be blocked by using medications to treat them. So what is arthritis in an anatomical level? What's going on in the joint? So this is an example of the knee. So you have the femur, the thigh bone, the tibia, the shin bone, and the patella is the kneecap. And what we see here is there's increased fluid and the lining itself is thickened. And that's what's causing the arthritis. So you have the joint swelling is the most important part for arthritis. You can also manifest with pain or limitation of motion, warmth, or redness. So here is an MRI image of a 6-year-old girl with juvenile arthritis. And what we see is this is again the knee. So the femur bone is here, the kneecap is facing this way. All this white stuff is the lining of the joint, synovium that's thickened. All these little black pockets are fluid. And this is a horizontal view of the same knee. And you can see again the thickened lining of the joint, synovium, as well as fluid in between. So this indicates that there's a lot of inflammation going on. And when we look at what's happening inside the joint, typically we have immune cells called the T cells, the T lymphocytes. They interact with what are known as macrophages, and a variety of protein cytokines are made. So there's one called interleukin 6, there's one called interleukin 1, and there's one called TNF-alpha, and they tend to be in a loop so that one brings more of the other and vice versa. And eventually this leads to damage to the joint, both the cartilage and the bones, as well as proliferation of the lining, the synovium. It's called pannus is the name for this. And there's also this particular enzyme called cyclooxygenase that leads to something called prostaglandins. And this is what's responsible for the pain and the swelling and the redness and so on. So when we think about medications, one of the first things we use is NSAIDs, or non-steroidal anti-inflammatory drugs. These are things like ibuprofen, naproxen, and they block prostaglandins, and they are pretty commonly used. And they can be used with other medications as well. And then we have certain medications such as prednisone, methotrexate, or leflunomide, and these are generally broadly decreasing proliferation of cells or division of cells. Therefore, it slows down everything in the joint. And then there are 5 different drugs called etanercept, infliximab, adalimumab, golimumab, and certolizumab. These are all proteins made in the lab. They're antibody treatments, and they are given to block this TNF-alpha that leads to control of arthritis. There are 3 different blockers for interleukin-1, anakinra, rilonacept, and canakinumab. And then there's one that blocks interleukin-6 called tocilizumab. And there is one called abatacept that blocks the T cell from getting activated. And finally, there's one more drug called rituximab, which blocks the B cell. And this is just some of the medications. And we have more and more newer and newer medications being introduced every year. So this list is always in need of updating. But this gives generally an overview of most of the medications we use, definitely most of the ones we would be using in the first couple of years since diagnosis. So I'm going to talk about each of these medications a little bit. So the non-steroidal anti-inflammatory drugs are the most commonly used. So these inhibit inflammation, and children eliminate these medications rapidly. So oftentimes they may need a higher dose than adults even sometimes based on their body weight. It's very good for treating both the pain and the fever, but it's not necessarily good for treating inflammation, and these may not change the long-term outcome. So in other words, just taking naproxen is unlikely to cure the arthritis, so we may need to go to other medications. They also can take between 2 and 12 weeks before they start to work. Now, when you have just a limited number of joints, we can use intra-articular steroids to treat the arthritis. So here we inject medication into the joint, sterile, take out the fluid, and then this can be very helpful in treating arthritis for anywhere from 6 months to 2 years, depending on the kind of arthritis and the individual child and the medication used. And in this picture, you can see this child has a huge swelling of the right knee. And within a few weeks of injection, you can see that the knee is completely back to normal. And you can see that the child is no longer having the swelling. Now, the next medication is something called methotrexate. This was the most commonly used, what we call DMARD, a disease-modifying anti-rheumatic drug. And this was discovered by this pharmacist, Dr. Subbarao, and Dr. Sidney Farber. You may have heard about his name, the Dana-Farber Cancer Institute. He's an oncologist, and he started using it for leukemia in the beginning. But later on, it was found that it's very useful in other autoimmune conditions. And it is used in many rheumatic diseases, both juvenile arthritis, rheumatoid arthritis, as well as other conditions like Crohn's disease and psoriasis. It can be given orally as a pill or as by injections. And sometimes the injections work better. The onset of action is usually between 6 and 12 weeks, and generally labs are needed every 8 to 12 weeks when you're on this medication. Most children tolerate this well, but a good number of them have some nausea and mouth sores, and that can make it difficult to use this medication sometimes. Now, the next line of medication we most often use after we start with the naproxen and methotrexate kind of medication is something called anti-TNF agents. And these block the tumor necrosis factor, which is one of the cytokines I showed in that slide earlier on. So there are quite a few different medications to do this, and they're all similar. And so I'm only going to talk about a couple of different examples. And they essentially bind to the TNF that's circulating in the blood and decrease the amount of inflammation in the body. So etanercept, also known as Enbrel, a commercial name, is the first biological agent that was approved in juvenile idiopathic arthritis. It was used first in children with fairly advanced arthritis because it was the first clinical trial. So only kids who had failed methotrexate and who had really active disease went on this medication. It was given initially twice a week. Now it's also given once a week, and it's given as a subcutaneous injection. It has a very long history of use in juvenile arthritis as well as rheumatoid arthritis. And what the slide at the bottom shows is that within 3 months, 80% of children who got this medication demonstrate at least a 30% improvement in their joint disease. So in other words, if you have 10 joints, a 30% improvement would mean that at the end of 3 months, 3 of those joints no longer have arthritis. But more interestingly, about 40% of children had a 70% improvement. So in other words, 40% of children had 7 out of 10 joints get better after just 3 months. And remember, these are children who had fairly severe arthritis because that's why they agreed to participate in the study, the first of its kind in juvenile arthritis. And then what the researchers did was take these children who had at least this much response, take these 80%, and then either they continued the medication or they were randomized to get the placebo, and nobody knew what they were getting. And what we noticed was within 3 weeks, the kids who were on placebo quickly flared. So their disease flared, so that in fact, by a few months, by 4 months, almost all of the children who received the placebo flared, whereas the children who got the etanercept, 80% of them continued to do really well with their disease under control. So this was the demonstration that this medication can make a big difference in treatment of juvenile arthritis. So adalimumab or Humira is the next one that was approved. And this is a recombinant humanized antibody. That means the protein looks very similar to a human-based protein, and therefore it's more acceptable by the immune system. Also, it is also had to be given by injection. It's typically given every other week. Sometimes it may need to be given more frequently than that. It works really well either alone or in combination with methotrexate. And this is the molecular structure of this medication. And what this shows is at the end of 2 years, 104 weeks, and 90% of children had at least like a 3 out of 10 joint improvement, whereas about 40% of children had 100% improvement in their arthritis. That means their arthritis is essentially gone. And that was amazing to see that, so many children could actually get to that level. And more than 60% of children had a between 90 and 70% improvement. So that makes a huge difference if you think about a child who had 10 joints at the onset of their disease and now only has 1 joint, that's usually a very big difference in their activity of daily living and their ability to do their own chores and so on. Now, another category of medications are the interleukin-6 blockers. So interleukin-6 is another cytokine, and tocilizumab or Actemra is a monoclonal antibody that binds to IL-6. And once this Actemra binds to the receptors, it prevents the IL-6 from, joining the receptor and creating the response inflammation. So it's used both for rheumatoid arthritis, systemic JIA, as well as polyarticular JIA. It's given as an IV infusion every 2 to 4 weeks, and a subcutaneous version is also available now. And again, very similar to the other studies, it shows a substantial number of children have a really quick improvement of their disease within a few weeks, and then they maintain it over time. Interleukin-1 is another cytokine and seems to be more particularly prominent in systemic JIA, systemic juvenile idiopathic arthritis. There are 3 different drugs for this. Anakinra is a subcutaneous drug that's given every day. Canakinumab is something that is given every 4 weeks by injection. And then rilonacept is something that's given once a week. So there are 3 different choices, and they all have different advantages and disadvantages and effectiveness rates. Now, I've talked about some of the medications we use to treat arthritis, and we've also talked about what arthritis is and what are the different types of it. And now I'm going to talk a little bit about the philosophical approach for treating juvenile arthritis. And first, I'll do what we used to do. This used to be the traditional way of treating arthritis. We start with an anti-inflammatory medication. So these could be naproxen, meloxicam, nabumeton, Celebrex, diclofenac, or something like that. And then we quickly added what's called a disease-modifying anti-rheumatic drug. I gave the example of methotrexate, which is the most commonly used medication. There are some people who use leflunomide. There's one medication called sulfasalazine, and there's one called hydroxychloroquine. These are used less commonly, but they're also options for some children. And then we move on to the TNF inhibitors, so etanercept, adalimumab, infliximab, or Remicade is another option. So that's usually the next. And if that doesn't work, then we go on to other agents. There's tocilizumab or Actemra, abatacept, or rituximab. And then if none of these work, then you're really looking at more severe kinds of medications, Cytoxan or using something called a bone marrow transplant. And this fortunately is very rare. And these are done in a very limited number of cases where everything has failed and or there's no, there's some intolerance to some of the medications. So fortunately, with early treatment, most of the time we don't need to resort to such extreme measures. Now, there's also always something called a home exercise program. So physical and occupational therapy exercises at home is important. You may also have to go see a physical therapist, occupational therapist, depending on the child, and if there's a contracture that needs to be treated. Steroid injections can always be beneficial. And then occasionally we have to use steroids by mouth or by IV when there's severe flares of arthritis. Again, this is fortunately less if we have the disease under good control, but sometimes for breakthroughs, they may need to use these. Now, instead of giving one medicine at a time and adding, it's just a step-up therapy, there is also a thought process of using combination at the beginning. So this is an example from 2011, but what they did is they took 60 children with JIA who were recently diagnosed within the first 6 months, and they were either given methotrexate alone, or methotrexate and infliximab, or Remicade, or methotrexate and 2 other medications, sulfasalazine and hydroxychloroquine. And so these were followed over a 1-year period. And what we found was, what is the proportion of children that got a 75% improvement? So ACR 75 means a combination of factors that include the number of joints and the number of joints with swelling and limitation and pain and so on. And that allows us to look at it as a endpoint. So if you have a 75% improvement, that's a significant improvement. And almost 100% of the children who got the combination therapy got to that, whereas only 50% of the children who got only methotrexate got there. And then clinically inactive disease means you don't find any evidence of arthritis at all. Almost 70% of children who got the combination therapy got there, compared to about 1 in 4 children who got the methotrexate. And the ones with the combination non-biological medications is something in between. So what it means is, instead of using a step-up therapy where we keep adding medication after the previous one fails, sometimes that means it could take 9 months, 12 months, 15 months to get somebody under good control. As opposed to that, if you were to use more than one medication at the beginning of the disease, you could get it under control and then maintain it with fewer medications. So this is a slowly changing paradigm. And in fact, CARA has a protocol and a study that is exactly looking at this question. Now, so this gives an overview of the different types of treatment and approaches we have for arthritis. Generally, I want to end by saying that juvenile arthritis has different kinds of presentation. So not every child has the same type of arthritis, and therefore not everybody needs the same kind of medications. There's a variety of treatments available, and this has been a huge bonus. When I was in training, we only had a limited number of medications available, and today we have so many more. And this also allows us to use medications more earlier, and we're able to treat children in a more personalized manner so that each child and the family can decide what is the best treatment for them with their pediatric rheumatologist. We also need to emphasize that multiple specialists are involved in the treatment of arthritis. And of course, the pediatrician is important, and as is the child and the family. But the pediatric rheumatologists do play an important role in seeing them regularly and making sure that things are addressed and treatment is on par. Ophthalmologist visits are important so that we can prevent, and if you recognize the uveitis, you can treat as soon as possible. So definitely there's screening required for that. Physical and occupational therapists are needed as and when we see a need for that. If there's need for improving the range of motion or strength or any particular joint that seems to be problematic, to correct posture, to help with pain and so on. And for those children who can have their jaws involved, sometimes this is something that has been noted. So when there's a TMJ involvement, then seeing a good oromaxillofacial surgeon or a dentist who specializes in that may be helpful so that that can also be addressed. But in all, I want to end by saying, in general, very good outcomes can be expected today because of, the specialization of pediatric rheumatology, the recognition earlier on by pediatricians of these conditions, the wide variety of medications, and frankly, the education. I think that all those watching this clearly have a need for learning more about arthritis, and then you seek out things like the Arthritis Foundation that allows us to give more information, empowering the children and the family to get the right treatment at the right time from the right provider. And this means that generally outcomes are much better than what we used to see. And I have a slide here that was courtesy of Dr. Dan Lovell, whom I trained under, had the privilege of training under Dr. Lovell in Cincinnati. And you will notice that many of my earlier slides with different medications, he was one of the primary authors of those studies. And this is a camp from the 1980s, and you can notice the number of children in wheelchairs sitting inside the arthritis camp. At least in this picture, we can see 3 children are in a wheelchair, and one child needing these walkers. And then compare that to more recently, and this is from 2014, from our own arthritis camp, Camp Akeway in Atlanta. And you can see that our children are much more active, and we can identify who's got arthritis and who doesn't. So definitely this has been a wide variety of options to treat these children that makes us be very hopeful that our children can have a very good future, and you can expect good outcomes. So I want to end by thanking the Arthritis Foundation for giving me this chance to talk to all of you. Of course, I always am grateful for the children with rheumatic disease and their families who allow us to take care of them and learn from them and participate in our researches, and the Marcus Foundation, as well as the other institutions that support me and my efforts. Thank you.
Thank you so much, Dr. Prahal. I also want to thank everybody for joining us here today at the JIA conference. And I want to let everyone know that Dr. Prahal will also be available live to answer any questions at the Doc in the Box on Saturday, July 24th. So if you have questions for him, or you just want to listen, go check out the conference app for more information. That Doc in the Box session is Saturday, July 24th at 5:30 p.m. Eastern. So, and we hope that you enjoy the rest of the conference. Thanks so much for being here. And thank you, Dr. Prahal.
Thank you, Katie.